Hi everyone, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota, Sanford School of Medicine. Today we're continuing our Anesthesiology 101 lecture series. We'll be talking about induction and different induction medications. We have a couple different learning objectives. So first we're going to discuss pre-oxygenation, then rapid sequence induction, different indications for doing so, and then the purposes of various common induction agents, including midazolam, fentanyl, lidocaine, propofol, rocuronium and succinylcholine, and phenylephrine and ephedrine. You might notice that the structure of this PowerPoint is a little bit different. This is more of your traditional PowerPoint slides. I am sorry, I hate these myself, but a lot of this lecture is memorization. So just having the information in front of you is kind of the primary goal in presenting it. So to begin, we'll discuss pre-oxygenation. That's the deliberate practice of replacing nitrogen in the patient's functional residual capacity with oxygen. It's also known as denitrification. Dr. Toom, he really likes to emphasize the idea of denitrification. It's the same aspect of pre-oxygenation, just a different way of saying it. And one thing kind of unique to pre-oxygenation is going to be fully saturating the hemoglobin with oxygen, whereas denitrification is more focusing on replacing the nitrogen that's in the lungs in the functional residual capacity. Pre-oxygenation includes that, but you're also fully saturating your hemoglobin with oxygen, and then there's also dissolved oxygen within the blood. You want to maximize the amount of oxygen that's saturated in the blood. That just buys you time when a patient is apneic because they have more oxygen available for their tissues to use, so they can be apneic for longer. You have more time to intubate them. Rapid sequence induction is performed on patients who have an increased risk of aspiration of gastric contents. So the goal is if a patient maybe has an unknown fasting status, or you know that they have a full stomach, but for some reason they're having emergent procedure done and they need to be intubated, then you want to minimize the time between making them unconscious and getting a tracheal intubation airway secured. Because in that time, when they are unconscious but they don't have a secured airway, if they vomit, then they don't have any glottic reflexes that would prevent them from then inhaling their vomit and then causing difficulty breathing in the moment, but also an aspiration pneumonitis down the road where the acid of the gastric contents kind of like burns the pulmonary tissue. So different indications include clinically significant GERD. So that would be if you see a patient in pre-op and they say that they have a history of heartburn and today they're having heartburn. Or right now they're having heartburn, then you would consider doing a rapid sequence induction. Delayed gastric emptying, so maybe a diabetic patient could have delayed gastric emptying. If they have a history of that, you would consider, this is also known as RSI and RSI. If they have an unknown fasting state or a full stomach. A new indication for rapid sequence induction that's a pretty hot topic is if a patient is on GLP-1 agonist and they haven't stopped taking that. Most recommendations say 2 weeks beforehand. GLP-1 agonists, those are used for weight loss. Part of their mechanism is they delay gastric emptying. So if they're on one of these medications, especially if they've started it recently or if they have a history of nausea with it, then you would consider doing rapid sequence induction on those patients. The most serious complication of a rapid sequence induction is you might not be in an optimized setting. So maybe you're in the emergency room having to intubate a patient rapidly and emergently. And then you will paralyze them with succinylcholine, and you have to then manage the airway of a paralyzed patient, which is the case with just about all endotracheal tube intubations. but you might not be in an optimized setting, or you might be doing it emergently in a sick patient. And then, yeah, you're managing the airway of a paralyzed patient. That's the most serious complication. So, in one of our previous lectures, we talked about the 7 different pillars of anesthesia. Conveniently, they all start with A. Um, we're going to assign these different goals of anesthesia with different anesthetic medications. So, for example, propofol causes hypnosis, where a patient loses consciousness, falls asleep. But it also affects a lot of these other ones as well. We'll go through one by one. Before we do that, let's just review what each of these are. So, anxiolysis is relieving anxiety. The big medication that you'll see for that are benzodiazepines, or midazolam is used most commonly. Amnesia, inability to remember, also seen with midazolam. Anesthesia, or I call it just hypnosis. Anesthesia is a pretty vague term. Hypnosis doesn't start with an A, though, so I think that's why they assign it this way. But that's loss of consciousness, so like in quotes, falling asleep. Analgesia is pain relief. Akinesia is paralysis, so not moving. Areflexia is causing muscles or autonomic systems that don't respond to stimuli. And then autonomic control, I defined as maintaining desired vital signs. Let's jump right into our first IV induction medication, so midazolam. The 2 primary goals of midazolam is going to be anxiolysis and amnesia. So if you give it to a patient in pre-op who's anxious about their upcoming surgery, that can make them less anxious. And then it's very common that if you give this to a patient in pre-op, that they won't remember the transition back to the OR. Sometimes if you have a concern about awareness under anesthesia, you could also give it in those circumstances as well to try to cause amnesia, and lead to a more pleasant anesthetic experience. Other goals, secondary goals, it can cause areflexia and muscle relaxation, analgesia, so it's helping with pain, and then it can also be used to put a patient to sleep. Interestingly, it can actually be used as like an induction medication like propofol, etomidate, ketamine, where you can induce a patient solely with it and have them go to sleep. You have to use very large amounts of it, so it's not a very common thing to see. But it would be a medication that you could induce a patient with. So fentanyl has a couple different purposes. The big ones are going to be analgesia, so it's helping reduce pain, which makes sense because fentanyl is an opioid. Areflexia, the big thing here is it can reduce vocal cord spasm during intubation. It helps with autonomic control and reduces the sympathetic response during laryngoscopy. And then it can also help with anesthesia or hypnosis. Um, Maybe like the evidence of this one is you are decreasing your MAC requirements. So if you need to keep a patient asleep without fentanyl, it's going to require more concentration of an anesthetic gas to keep them asleep, but you can actually decrease your MAC if you're using fentanyl. Lidocaine, like fentanyl, has a primary effect of areflexia, so it relaxes the vocal cords during intubation. And then it also, because it's a local anesthetic, has some analgesia effects. The big one that you'll hear cited is if you give lidocaine right before you give propofol, then sometimes that can help reduce the burning that the propofol causes when it's administered via IV. Propofol is primarily a hypnotic medication, so it produces unconsciousness. It causes the patient to fall asleep. It has very limited or no analgesia effects. It pretty much does everything outside of analgesia, so it can cause amnesia, areflexia, which again helps during endotracheal tube intubation, autonomic control, where you don't get massive sympathetic responses when you are intubating a patient. If you use propofol, it can help reduce that sympathetic response. Akinesia, so it can even help patients hold still. And then anxiolysis. So it can be used in small doses, 10 to 20 milligrams IV to relieve anxiety. This could be useful if you bring a patient back to the OR, and I've seen it done um, if the patient's very anxious on the table. So perhaps you have like an autistic patient or a non-autistic patient, but they're very restless, then you can give 10 to 20 milligrams IV to help relax them in the OR. So rocuronium and succinylcholine are medications that produce a neuromuscular blockade, so they paralyze a patient. Their primary goal is going to be akinesia. And then phenylephrine and ephedrine are vasopressors, so they can increase blood pressure and heart rate. You're going to be using those primarily for autonomic control to maintain desired vital signs. I hope that this lecture helps. If you guys have any questions, feel free to reach out to me or any of our attendings at Stanford or Rapid City, Avera too. I'm sure that we'd all be glad to help. Thank you.